All right, well, why don't we get started just so we have enough time for discussion. Thanks everyone for joining this morning. We're in our second to last month of nephrology grand rounds for this academic year. This morning we have Dr. Rodriguez who will launch grand rounds for the first 30 minutes. And I know we'd like to have some discussion, and then following that we'll have biopsy conference led by our renal pathology colleagues. So Rudy, go ahead.
Yeah, thanks. Today what I wanted to talk about are kind of nephrology certification requirements for fellows for training. And it truly is a kind of a year, this is kind of the year we'll be making a decision. And I just wanted to give you some background, especially for, I think, for current fellows who may not know some of this history. Let me just, this is something I have to show is because I am on the ABIM board. I'm actually the chair of the nephrology board for the ABIM. And obviously I won't be talking about exam questions or things like that. Some of these slides that you'll see were created by Sid Reddy, who works for the ABIM, so I thank him for these. And I'll be giving you a little bit of background, and then some of the faculty probably have answered at least 2 ABIM surveys, and I'm going to give you the results of those surveys that we did last year and just recently. Talk just briefly about community input, next steps, and then hopefully the last 10 minutes or so, or 15 minutes, there'll be a survey for all of you, and then hopefully time for discussion. These are the current ACGME requirements. So this is what the program is supposed to be teaching our fellows per ACGME. These are the required procedures. As you can see, it includes acute dialysis, acute and chronic, CRRT, biopsies, both native and transplant, PD, temporary access, and a urinalysis. ABIM requirements just mirror the same ones, as you can see here on the right. So at the end of the training, the program director has to attest to competency. So what Yoshua Hall has been doing over the last few years is saying that all the fellows are competent in all these procedures, including biopsies and putting in IJ lines. If he were to say no, or carry now, that one of the fellows was not competent to put in catheters, and then you can't sit for boards, actually. So that's the implication. Interestingly, this slide I'm showing you right now, I created this slide actually in 2013 for a lecture for a kind of debate I did with Stuart Shanklin about this same topic. So again, one of the reasons this has been going on for a while and we haven't made a decision, but one of the things to realize, this is a study by Jeff Burns who surveyed programs, and as you can see, where 20% of programs said, fellows were just doing 0 to 2 lines, or 0 to 2 femoral lines, very few biopsies, as you can see. Jeff Burns did a survey of recent graduates of fellows, somewhere in the mid-hundreds of fellows who had already finished. And their responses were that, as you can see for kidney biopsies, almost 20% said they had little or no training, but felt they weren't competent. If you look at IJ lines, got up more, about 40%, they either had little or no training or not competent. And the implication then is that if we, from the ABIM standpoint, we don't actually, there haven't been any fellows where program directors have responded that people aren't competent. So this is why this has become an issue, that either we have to make sure training's happening or change the requirement. And this is, also home hemodialysis is not actually a requirement. And in this survey, the fellows, that's reflected, right? Probably only 15% felt well trained on home hemodialysis. But also chronic PD training, which is a requirement. 40% of these respondents said that they had some training, but did not feel competent. Stuart also did like an article on kind of debating kind of he gave the he gave the side of that catheters and biopsies are not needed. Jeff Burns saying yes, and then more recently in dialysis in Kidney 360, the same debate is happening. So this is again why this is a kind of a time for a decision. The debate is basically pro keeping procedures a requirement. Is that despite low volume, nephrologists may need to place a catheter for acute dialysis emergently. You may end up in a rural practice that may require the skill for biopsies and catheters. Some people argue that procedures attract interest in nephrology, builds trust with patients. And I even just this morning, actually, I was talking to a nephrologist in private practice who said, yeah, IR just many times will give these tissue with inadequate tissue so that when nephrologists do a biopsy, we're more likely to get better tissue. The other thing is if we give this up, non-nephrologists may be able to manage to GNs. If you look at a lot of the papers published about certain GNs, they're actually the first author is a rheumatologist. And this may happen more and more. The cons are mostly focused, I think, on time, money. Reason to get rid of it is that most nephrologists aren't doing these procedures. Safety, that maybe it's safer for IR to do both lines and biopsies. So from the standpoint of ABIM, what we're doing is we've completed kind of we're going through the process of seeing what should be done. We've polled nephrology diplomates, or not fellows, but basically people who have finished training. We're next going to engage, we are engaging non-program director stakeholders like the NKF, the American Association of Kidney Patients, who else? The RPA, and then the ASN has decided to kind of start a huge, kind of a year-long process of really envisioning kind of how nephrology training, nephrology in general should change. So let me quickly give you some of the data from these surveys that we've done through the ASN. We did two. One is to survey how often nephrologists are doing these procedures. And then we went back and asked them, should we keep this requirement for training, change it, remove it? We looked at some emerging procedures, and then also whether we should start a new requirement, which is an opportunity to train. So instead of, for example, biopsies being a requirement for our fellows to be trained in, an opportunity to train would be that that if a fellow wants to be trained, the program would be required to actually train that fellow to a level of competency. So that's another choice. So there are, so 10,000 nephrologists was a survey outreach. There's the standard inclusions, and it was an online survey. The second survey was from February till March 18th. We got about a 20% response rate, 2,200 answered. You can see pretty close demographics. Respondents were more likely to be participating in maintenance of certification. So what you'll see in these next slides are the procedure. Kind of here on the left is how frequent people are doing them, and on the right is the second survey of whether the nephrologists thought that we should keep these procedures, change, remove, or change it to an opportunity to train. So frequencies, and then their opinion about how fellows should be trained. So first one is dialysis catheters. As you can see here on the left, 71% of nephrologists said they no longer perform any catheter placements. 1 to 5 said, or 14% said 1 to 5 times per year. And you can see the rest there. And pretty split. Again, that's why this has been going on for so long. About half of people thought it should be removed as a requirement. and about the other half thought it should be kept. But however, if you look at there at the bottom, the opportunity to train was the most popular. So 58% thought maybe it should be changed to opportunity to train. For biopsies of both native and transplant, 83% of the nephrologists said they no longer do these procedures. And you can see the rest there on the left. Most said to remove this, but again, if you look at the bottom, opportunity to train was the most popular option. Change it to opportunity to train. I won't spend much time for kind of these, that we knew that these were, everyone would not want to change acute dialysis, which is our bread and butter. CRRT, the same thing. Everyone thought we should keep it. Chronic outpatient dialysis. Here it's just notable, the percentage, 31% of respondents said they had more than 100 patients, chronic patients. 34% had 51 to 100 patients. So everyone thought we should keep this, of course. PD, the same thing. Although, as you can see, that good percentage, twice as many as chronic dialysis had said it was not part of their practice. Other 20% only had 1 to 5 outpatient PD patients. And then kind of emerging procedures like home hemo. It's not necessarily that it's emerging, but it's not a requirement, at least for now. Again, most people, it's not part of their practice, right? So 35% said not part of their practice. 43% had only 1 to 5 home hemo patients. And here, at least, there was a kind of support that this should be added as a requirement, that all fellows should be trained in home hemo to competent levels. And then 51% thought it should be, we should strengthen our requirements, and only 25% thought it should be an opportunity to train. Pheresis, this is not a requirement, right? That we need to be competent in the prescription of this. We know kind of when it's indicated, but we're not always involved, and that's true here at the respondents. 41% saying it's not part of their practice, and again, kind of split: add requirements and do not add. But 54% thought it should be an opportunity to train. Urgent start PD, thought people thought that this should be added. And then point of care ultrasound was added also. Should we think about adding this a requirement? And it's kind of split. The majority here is saying opportunity to train. As far as the comments, that the survey allowed comments, there weren't too many comments. Some comments focused on not giving these procedures up to NPs and PAs. Concern about getting rid of the procedure requirement because of rural providers, and concern about attracting future workforce. This is kind of a summary of what I just went over. It looks like, again, the dialysis catheter biopsies where most of the controversy is, but opportunity to train is thought it was the most popular option there. Home hemo, I think there was consensus, at least in this survey, to add it as a requirement. And then PD, urgent PD also. So next steps, as far as what we're doing for the ABIM, is to obtain input from societies. Again, ASN has this year-long process that they like to finish up by November's meeting. And some people, I think, are involved in that process. I think Sarah Sangavi, I think, is involved a little bit because they're looking at everything, including subspecialties within nephrology, like ICU care. We're also going to be obtaining some input from program directors, and then we'll probably make a decision probably in the spring of next year. So next thing I'd like to do is launch a survey of people that are here kind of online right now to get a little bit about your opinion. We can explain. I haven't. The questions will be the same for all of you. For example, it'll be, what do you think about dialysis catheters? So for fellows, it should answer. There'll be an indication for fellows. Some of the questions, whether you think it should be removed as a requirement, to keep the requirement, or opportunity to train. Remember, if you're answering keep the requirement, though, that means we're going to have to change really the way we're doing business, right? So like I think my understanding is that at the other sites, people aren't putting catheters anymore. So that may have to change if we're saying we should keep this requirement. Opportunity to train would just mean that then the program, if a fellow wants to be trained, that we need to kind of come up with a plan. And then, so that's the survey. So Matt, I don't know if you want to go ahead and launch it.
Yes, so just note for folks, so questions 1, 3, 5, and 7 apply for fellows, and then everyone else should answer questions 2, 4, 6, and 8.
So you can see number 1 says fellows, number 2 says faculty. So same question. Yeah, same question, but the one with the red star is for faculty. Matt, did it launch all the questions or just that one question?
It should have launched all of them. You just have to scroll down to get to the other ones.
Okay.
And I see 8, but it's not letting me submit.
Yeah, I think that's the
case.
case. I think if you only answer the 4 for faculty, then you can't submit.
Interesting. Yeah, Danielle set these up, so I'm not sure. We probably can't change it at this point. So
should we just answer the same?
I guess you'll have to. So Rudy, we're not going to be able to separate people by fellows and faculty, unfortunately.
Okay, that's fine. Just go ahead and I guess we'll get twice as many responses, but it's all right.
I'm just confused. Why can't we remove a requirement, but also give an opportunity to train? Because that's when we remove the requirements, we usually still want to provide opportunities to train, but you can only choose one of those.
Right. So if you're removing the requirement, that means you're removing the requirement that all fellows should be trained. And instead, the opportunity to train would be if a fellow expresses interest that they want to learn how to put in catheters, then the program would be required just to train the people.
Right. No, I understand what the choices are, but usually if I want to remove a requirement, I also want to provide an opportunity to train if the fellow wants it. It's not mutually exclusive. So that's what I'm confused about. So when we did this for the ABIM, you could remove a requirement and provide an opportunity to train. It wasn't one of the above. It was like remove or keep, and then would you like to provide an opportunity to train? So that's, I don't know, at least that was my recollection. So.
Yeah, I think my understanding of it is that if you choose opportunity to train, you're saying we should remove it as a requirement.
Okay, so that
and provide an opportunity to train.
Got it. Okay.
There's no keeping the requirement up. And so I think it has more to do with whether programs would be required once the requirement is removed to provide the opportunity or not.
Got it. Because that's why the numbers don't add up to 100 from the original stuff Rudy showed. I mean, you could, you know, like, so,
Right.
okay. All right. So just choose opportunity to train if you're okay with removing it. Okay.
Right.
Okay. Okay.
So can everyone see I shared the results, Rudy? I think they're there.
Oh, are they? I don't see them.
I don't see. So
No one sees
Should be a
them?
pop-up. I see them.
I see them. in
I
the
can
pop-up.
see them.
Oh, could you do it again? I thought I didn't answer it, so I thought it was probably asking me to the poll when it popped up.
Yeah, if I stop it though, it's gonna probably require everyone to answer again, which,
Or could you just share your screen then of the results?
yeah, can you square your sheet? We can't see them.
hang on.
There's a tab in the bottom that says polls. If you hit on that polls, it'll show you the results.
Oh, I see it. Okay,
Got it.
I got it.
Got it.
Oh, well, instead of sharing screen, I guess we can all see it, right? So for catheters, it looked like most people thought opportunity to train would be biopsies, keep the requirement, was the selection. PD, I think almost, I think the 34% thought keeping the current requirement with no changes, 41% thought we should set a minimum number of patients, 25% thought setting up a rotation. But overall, it sounds like 66% of people think we should strengthen the requirement somehow. Home hemo, add the requirement. All right. So one second here. So I just wanted to kind of open it up, but hopefully everyone can just, I don't know how do you want to do this, but it would be great to have a discussion. I think about this, about how these, about the changes, but also some of the other results, right? So for example, point of care ultrasound, urgent start dialysis and plasmapheresis. Just wanted to hear some opinions about the poll results or other things. So maybe why don't we start with the poll results? Because the implication again is that we would get rid of the requirement, let's say for catheters, it sounds like, and that would be an opportunity to train. Why don't we start with that? Is any arguments either way, but it seems like that was the consensus. Carrie, as the program director, and kind of Yosha is the most recent one. What do you think?
Yeah, I don't know. When we polled our graduates, there was only one graduate over the last, I don't know, 15 years who answered that they were doing these in practice. So just like everything, it's probably a little bit more, it's like politics, it's a little bit more local in terms of sort of meeting the training needs of your constituents. So I think it's kind of reflected by that.
One thing I would just say, sorry, Carrie, were you about to talk? No, I'm just.
You can talk.
Now, the one thing I was going to say is that, there's a lot of things we don't do in practice just because it's not cost effective or because of the model of practice not supporting it. But understanding the risks of procedures when you're trying to engage in shared decision making with a patient can be really helpful. And despite not actually doing it in practice, it may be, the training period, I think, is a good time to get a good sense of the risks involved in a procedure that you're prescribing. And I think that probably makes more sense for kidney biopsy than putting in a temp dialysis catheter. But that's just, one other pro, I think, of training fellows on these procedures that hasn't already been stated.
For catheters, like one of our board members would always relate, he's from Texas, where part of his group was, would cover hospitals where if someone needed acute dialysis and that was frequent at night, they were the only ones that could actually put these catheters in during those times. So that's one of the reasons they were hoping that this didn't go away. But the opportunity to train is a middle ground, but many times people don't know what kind of work environment they're going to end up in. So opportunity to train also, like over the VA, we have a procedure rotation. And that's one of the ways that, for example, this could be addressed, right? Is that people would go on that rotation where that's all they're doing are different types of procedures. So that's the kind of thing that would have to be set up as an opportunity, some way so fellows could be trained.
Ian?
Thanks, Pat. Sarah and Yoshio both make great points that I agree with. I was wondering, Rudy, if there has been more definition of what opportunity to train means, because it could mean a lot of things. And Yoshio brought up that things are local. If there's an opportunity to train, does that mean that all programs must offer that, or is it possible that a selected subgroup of programs could, and that fellows who really want that opportunity could go to those programs? And will there be any sort of formalization of an opportunity to train? Could there be a certificate or a badge or a rating or something that goes up and above and beyond the certification, the general certification to demonstrate that? Any thought into how this would actually look? Because we seem to be voting for this, but I'm not exactly sure what we're voting for.
So, the ABIM is one thing, right? But if we change our requirements, eventually probably the CGME would change it. So they would then, and that's what they've done for internal medicine. So a lot of procedures are now opportunity to train for internal medicine residents. So the requirement would eventually be that all programs would have to offer the opportunity to train in catheter placement. Does that mean currently what's in place is that all programs need to train all fellows on procedures to competency? But again, we know that's not happening. So again, that's why we need to do something, because otherwise, like if our program, we're not training people to put in catheters, that's going to put Kerry in a tough place, because he has to then tell the ABIM that everyone's competent to do these procedures, even though they may not be.
Just to build on Ian's point, I think, the opportunity to train things sounds like a nice middle ground, but I think when you really start to think about what that would look like, to me, it's unclear, right? I mean, we've learned over the last couple of years that in healthcare, we don't have like built-in redundancies. Like there's not just 10 extra ICU beds hanging out or 10 extra dialysis nurses, and there's not 10 procedures just waiting for a nephrology fellow to come along every other year and decide that they would like to take advantage of that opportunity. So I think it's unclear to me where, if this was sporadically, utilized, where that opportunity would necessarily come from. And I think what would end up happening is we'd be asking the people to whom we've given this responsibility in the hospital, because we don't want it when it's inconvenient, to then, help us, which I think is a challenge, right? Because we've given this up at multiple sites now, and we don't maintain control over those any longer at 2 of the 3 sites where our fellows rotate.
I would agree with Kerry. I would just add that, I think the reason many of us are in favor of kidney biopsies, in contrast to what the national results showed, is that the feasibility of that at our training institutions is easier, right? Those are elective procedures. We can schedule them. They work better with our schedules. Whereas hemodialysis catheters, if we're putting them in temporarily, then that means that's an urgent procedure. And we just haven't found a way to operationalize urgent procedures in our training institutions.
And the related issue is that, in reflecting on the conversations that we had when we stopped doing catheters, where that individual faculty had not done that procedure in a long time. And I think it probably saying the same thing, Sarah, that you were saying in terms of how we've been able to operationalize it, because the biopsies are elective. And so we got assigned 3 people to do it, and for the most part, and have a schedule. Catheters often are emergent. And to have a structure, we call upon 1 or 2 people or 3 people that still maintain the skills to come in, that is not sustainable. Or at least in our system, it's difficult to operationalize.
Well, one thing to remember that as internal medicine programs go to opportunity to train for, let's say, central line placements, right? One of the things that may happen is that if people want to go into nephrology, they'll, the programs would make it known that they want fellows or residents who are applying to nephrology programs to be competent in catheters, so that their programs in internal medicine at least would then make sure that those people are trained. So that people come to us already with some training.
We haven't heard anything from any fellows so far, and I was just wondering if there are any that are holding back from expressing themselves.
Lauren is ready.
Incoming chief fellow or any fellow.
Yeah, I mean, I actually do have some thoughts about this. I mean, so I placed a lot of lines in residency. I did not place them when I was a hospitalist. I'm not sure I would place the great line now. I will say that I think that ICUs and interventional radiologists probably do it pretty well. I think there's actually a difference with kidney biopsy, and we discussed this at Harbor Review and for a journal club. And again, it's not a perfect study, but looking at the Arcana labs, and they were comparing the miss rate between radiologists and nephrologists as far as kidney biopsy. I mean, at least from a huge center getting a ton of biopsies, I mean, nephrologists did better. And so I think anecdotally we're hearing stories of interventional radiologists not submitting adequate samples, and I think that's a real disservice to our patients. So I mean, I think there is a much stronger argument to require teaching nephrology fellows to do biopsies, or at least having a very strong opportunity to train, just because I mean, I think we do better, and we should take ownership of that.
There's a chat question about whether lines are required for residents and internal medicine residents, and they're not, and never have been. So it's all, but I think it has changed to an opportunity to train.
All right, so I think we could probably go on discussing this for the next 30 minutes. Unfortunately, we'll need to move on. Thanks, Rudy, and thanks to everyone for the discussion.